Good evening, and welcome to tonight's Medscape education program, Getting Social About Constipation. I'm Dr. Joel Heidelbaugh. I'm a clinical professor in the Department of Family Medicine at the University of Michigan Medical School in Ann Arbor, Michigan. Tonight's program is supported by an independent educational grant from Bayer, and I'd like to introduce tonight's colleagues.
Great. Well, thanks so much. I'm so excited to be here. My name is Diana Isaacs, and I am an endocrine clinical pharmacy specialist. I am also the co-director of endocrine disorders in pregnancy at the Cleveland Clinic Endocrinology and Metabolism Institute in Cleveland, Ohio.
Hi, and I agree. It's really exciting to be here for this social media event. I'm Amy Ladewski. I'm a physician assistant, background as a dietitian. I work within the Digestive Health Institute at Northwestern Memorial Hospital, and I focus in gastroenterology.
Well, welcome, Diana and Amy. It's great to have you both with us tonight. This will be an exciting program. Let's start off by talking about chronic constipation and specifically risk factors. And so we see a lot of this in our practices, and all three of us have very different practices. I'm sure we see a lot of this across the spectrum for each of us. But let's take a deep dive into what can actually cause or lead to chronic constipation.
I'll take the lead on this slide. First, I think it's important for us to recognize that there's two different types of constipation, right? There's the acute constipation that people may get when they're traveling or they were on a certain medication for a little bit of time or something they ate. And then there's more of that chronic constipation that's kind of hindering their quality of life. It's been around for the last few months. Maybe it started 6 months prior. And and then there's what is constipation, and that can be different for each individual. There's the hard stools, there's really having to strain to get it out, the infrequency of stools, that sensation maybe you're not fully evacuating, and then those obstructive like symptoms. And many patients will have a combination of a couple of those symptoms that manifest as what they perceive as constipation. There are multiple risk factors for chronic constipation, and I will say that in gastroenterology, constipation is very common. It's the number one condition that I manage, and I think a lot of patients feel that they're very isolated, but it is quite common. And we know that risk factors include being of advanced age, being female, physical inactivity, polypharmacy, meaning being on 9 or more medications. We understand that the brain-gut axis is a big factor for chronic constipation, where stress in patients with other mental health disorders may have an increased risk for constipation. So again, there's so many risk factors that are probably influencing a patient's risk for the constipation.
Thanks, Amy. And as you spoke about, constipation is clearly very common in your gastroenterology practice. In primary care and family medicine, I see this a lot as well. Diana, I'm sure you encounter this a lot in your practice. I always think it's really important to really get down to the basic etiology of what's causing this, as opposed to just saying, okay, you have some constipation, go try this or that. But in terms of defining it, because I find that adds a lot of validity to it, and a lot of validity not only to the constipation, but to the patient's symptoms. Can you talk us through some potential etiologies?
Of course. For a condition to be very common, it can be overwhelming for patients and providers to diagnose and treat really what that underlying etiology is of the chronic constipation. So here's a Venn diagram. We can consider 4 subsets of chronic constipation with significant overlap. So many patients have more than one etiology of their constipation. The most common kind is going to be our normal transit constipation, the chronic idiopathic constipation. And that is very similar to irritable bowel syndrome with constipation, but irritable bowel syndrome is going to have more pain as a predominant symptom. I see a lot of patients with evacuation disorders, what's called dysenergic defecation, where the muscles of the pelvic floor aren't coordinating appropriately to push out the stool. is a more common and frequently overlooked cause of chronic constipation. Slow transit constipation is less common, typically seen in patients with maybe other neurological disorders, other endocrine-related conditions that can slow the motility of the bowel. And then there are the secondary causes, which we'll review on the next slide.
Sure, and I think this is really where a thorough history for each patient is very important. Reviewing medications, even reviewing family history, I find sometimes may clue us into thinking about some of the medical conditions we might be screening for. Why don't you walk us through this as well, Amy? Thank you.
Of course. When you're seeing patients in clinic, it's easy to jump the gun and try to diagnose and overprescribe before we really take a step back and review the medications that patients are taking, as so many medications have a side effect of constipation. And Diana, as a pharmacist, you can certainly understand.
Yeah, definitely. Most medications list constipation as a possible side effect. So it makes sense the more meds someone's on, the greater potentially their risk could be of constipation.
Mm-hmm, mm-hmm. And, here's a common list of patients that are, cardiac patients on diuretics or calcium channel blockers, iron on Dancitron, which is an anti-nausea medication. I'll be talking about those on the upcoming slides for patients with pregnancy. Clearly, narcotics, opioids are a big factor that can lead to opioid-induced constipation. And Diana's going to be delving into more depth regarding the GLP-1 inhibitors and how those can cause constipation. I mentioned on the other slide about slow transit constipation and there being associated medical conditions. We'll see, diabetes, hypothyroidism, multiple sclerosis, Parkinson's disease as potential risk factors for that. And then there's pregnancy. I'll review on a upcoming slide regarding just the multifactorial causes in pregnancy that can lead to constipation. And lastly, there's anatomical. So I mentioned on the previous slide some anatomical causes regarding how the muscles are coordinating, but more objective findings such as prolapse, rectocele, strictures, fissures, all of those are very important to identify if a patient, especially if they're having pain and bleeding, as a potential contributor to constipation.
All right, here I get to dive in. So this is what I get very excited about. I use a lot of GLP-1 agonists in my practice working in an endocrinology clinic. It's funny, when they first asked me to do this program, Getting Social About Constipation, I was like, that is an awesome title. Are you sure you asked the right person? Because I don't work in a GI clinic. However, I work a lot with GLP-1 agonists. And so I get to focus on this, which is turning out to be a really significant issue because the latest data show that about 1 in 8 people in the US has tried a GLP-1 agonist. So this is truly affecting a lot of people. So kind of what's going on here? Why would we expect that there could be some constipation? Well, it turns out there are GLP-1 receptors in a lot of places within the body. And one of the areas that is being affected is it's actually slowing gastric motility, which can definitely impact that constipation. Also, GLP-1 receptors are impacting the stomach, the intestines, the exocrine pancreas, gallbladder, and liver. So it's impacting a lot of different components of the body. And one of the things that occurs, which is usually a very favorable thing, right, is that it is promoting satiety. It is making a person feel more full. And this is one of the mechanisms where it's indeed it's approved for weight loss and for obesity. Also approved for type 2 diabetes and many other indications. The indications continue growing, like sleep apnea, cardiovascular disease. So one of the things that happens when someone feels more full is they're not eating as much, and they tend also to not drink as much water. And so when there's not as much water, there's not as much bulk, this can contribute to constipation. Interestingly, though, diarrhea can also occur. So not everyone experiences constipation. And actually, in this little blue box, what you can see are the time to onset from the start of the GLP-1. And the good news is that when constipation occurs, it is most likely to occur when first starting the drug. And often this is when, if a person has more side effects, it's going to be when they're first starting to take the agent. So you see these rates are much higher. They're over 15% within those first 30 days. By the way, this is one of the reasons that we really like to start with a lower dose and gradually build up. So we don't want to start with like the highest dose. We really, all of them have a lower dose that we can start with. And then after a month, for example, then we can go to the next highest dose. What you will also notice on here is days 30 to 60 and then 60 to 90, that incidence of new constipation is much, much lower. So we're really going to be most concerned with that first part of it. And then Amy or Joel, anything to add on this?
Well, I certainly noticed this as well. And I think you make some great points. Sometimes it's very difficult if a patient is having a substantial side effect to say, this will pass, push through it, what have you, because they may want to stop the drug, they may want to switch to a different drug, what have you. But this data I find is very, very telling, because that's a substantial decrease from day 30 to 60, and optimistic really for patients.
Definitely.
Yeah, I was going to mention, I see patients in gastroenterology that already have constipation that want to start a GLP-1. And I still encourage them to try it and say, we'll navigate the side effects with you. Maybe we will lower the dose, stick with it. Hopefully, your body will start to improve and those side effects will get better.
Definitely. So I like this. This is great data to show the different side effects that are possible from these GLP-1 receptor agonists. And you will notice constipation's on there close to 30%. But what else is also right next to it is diarrhea. And these are very interesting because these actually, so one person could have diarrhea, another could have constipation, but also the same person could alternate going from diarrhea to constipation. So both issues can actually occur. There also can be other GI issues too, like for example, nausea is probably one of the more common ones that we also see, which if that gets bad enough, that can also lead to vomiting. But this data here is actually taken from real world data from a retrospective study that had over 10,000 adults with diabetes or obesity that were newly initiated on a GLP-1 receptor agonist. And one thing, if you're familiar with any of the package insert or randomized control trial data, you may notice that this is actually a little bit higher. And in the real world, things can be done differently. Sometimes people may go to a higher dose, or they may not get the same type of counseling of education on ways to mitigate some of these side effects. So it's always nice to have that combination of real world data as well as randomized control trial data. And also just noticing too, abdominal pain, you'll notice that's a little bit higher. And of course, abdominal pain could come with constipation as well. So very helpful to kind of see both of those, see all of the data and kind of what's happening. And that's another reason why we want to really address constipation, because it can be painful for a person. Now, anyone who's really familiar with the GLP-1 drugs may notice that there's a prominent one that's missing here, and that is tirzepatide. That's a dual GLP-GIP receptor agonist. And that's simply because when this data was collected, tirzepatide wasn't included. That is actually our newest agent, even though it was approved in 2022. It came around a little bit later. What I can tell you is from separate analyses, we see very, very similar rates with tirzepatide as well. So this is very much a class effect, not just one particular agent. And honestly, there can be differences between agents. I have had patients that on one may do better on another, but it's not clear from looking at the data that we can say, oh, for sure, this agent is going to be better than that one. It's very much individualized, and probably other factors too, like a person's diet, physical activity, and other things that are happening. Yeah, Joel or Amy, anything else to add to that?
I'm surprised the risk of GI bleeding is so high. I remember seeing that for the first time I saw this, but I appreciate that you explained that overlap, Diana, relative to both abdominal pain with constipation, but abdominal pain with diarrhea, and obviously a myriad of factors that are at play there. So thank you.
Oh, you're very welcome. All right, well, now we're going to ask the audience who's all tuning in right now, we would like you to reflect. If you can think of a case of a patient that had constipation on a GLP-1 receptor agonist. So I'll give you a moment to think about that. And as you're perhaps reflecting on that, I'm going to go ahead and share a case with you. So I had a patient that we were titrating up on a GLP-1, and just so you can get the full picture, I am going to say the generic name, semaglutide. So we had titrated up. We had gone from the 0.25 to the 0.5, and then I got her up to the 1 milligram weekly. And she was doing actually very well with the titration. Yeah, she had like occasional diarrhea, a little bit of nausea, but we went up according to the usual titration schedule every 4 weeks, and it was going pretty well. So naturally, our next step was to go up to the 2 milligram. And I should preface this with, this is a person that has type 2 diabetes. So we go up to the 2 milligram dose, and suddenly she started to experience, she let me know she was experiencing constipation. She hadn't had a bowel movement in several days. It went on like practically it was a week, and she started to have some abdominal pain and said that she was very uncomfortable. So my first step is always, all right, lifestyle, like what's going on? Is there a change in diet? Is she experiencing other GI side effects from the dose increase? And it turns out that she was. She said that she was actually feeling a little bit more nauseous. She was not as hungry. And she stated she was not eating as much. She admitted she probably wasn't drinking as much either. So obviously I encouraged her to try to make sure that she's drinking plenty of water. If nothing else, drink plenty of water, but also focusing on eating higher fiber foods in that situation. And what we ended up doing was we actually had her take a stool softener. We had her take some Docusate in addition to trying to increase her fiber in her food. And then I actually backed back down to the 1 milligram dose because she was so uncomfortable. Fortunately, when we backed back down to that dose, she was doing a lot better along with these other, the Docusate was pretty short-lived. It was just to kind of get her through, get her to having regular bowel movements again. And we actually, a couple months later, with kind of some better planning of really making sure, okay, let's keep an eye on this. Let's drink plenty of water. Let's have the high fiber foods. Let's not try to like change diet as we're going up on the dose. I'm happy to say that we were able to titrate her up onto that higher dose, which we wanted to do for her diabetes to get her A1C to goal, as well as she benefited from that additional weight loss. So that's my story. Amy or Joel, any stories that kind of cases that you would want to share?
Amy, I don't know if you have one. I have one I can share, but I can let you go first.
I don't have a specific case, but more, in regards to patients I'm seeing in gastroenterology that do come in with pretty severe constipation from GLP-1s that may have had constipation beforehand. And with, optimizing their laxative regimen, whether that's over-the-counter prescription therapies, we've certainly have been able to get it better controlled. In regards to the over-the-counters, which is really the focus of today's presentation, by kind of layering on something like polyethylene glycol daily, or even having rescue options, the Senna or the Bisacodyl on hand, maybe, around the time that they have the injection, if they're able to see, the cycle as far as when they're having their constipation, and really counseling them through that. And I think counseling the patient before they start the medication as far as what to expect and have them prepared, I think is a really important piece to their management plan.
Thank you so much for sharing that. Because, as a pharmacist, what I don't want to see is that we're treating one drug with another drug. It's causing a side effect. And then we're like, well, we'll just add another couple drugs to treat the side effects of that, right? Like we would rather use drugs that don't cause side effects. But I think in this case, often it is all about rescue medication, going up on a higher dose, newly starting the drug, just to get someone through that beginning time. And then we can ease off. We don't have to keep those drugs on forever.
Mm-hmm. Mm-hmm.
So let's dive into the etiology of constipation in pregnancy.
Okay. Being a mother of two, I have a 7-month-old, this is certainly a topic that I can relate to personally, as well as a gastroenterology physician assistant. And we know that constipation in pregnancy is very common. About a third of pregnant women will experience constipation during pregnancy or soon postpartum. It's considered like the second most common side of GI symptoms, second to nausea. However, I think they're pretty much similar as far as the rates can go. To some people, constipation may seem pretty minor, but constipation can be very severe for pregnant women. And, it can lead to fecal impactions, causing ER visits, severe anal fissures and hemorrhoids and bleeding and associated anemia, where they don't even want to go to the bathroom because it's so painful. It can lead to pelvic floor injury. It can worsen anxiety, depression, just because of how severe it can be and isolating for that pregnant and postpartum woman. We know that the etiology of constipation is multifactorial. Hormones are a big factor, especially in that first trimester, with the progesterone-driven hormonal effects on gut motility, leading to more slow transit constipation. We can think anatomically, as women are getting bigger, that it's more of kind of an obstructive presentation on that rectosigmoid colon. Another hormone, relaxin, relaxes the pelvis and cervix, preparing for delivery. And that can also decrease the iliosmooth muscle contractions, causing slow bowel transit. We know that then there's medications, which I had discussed earlier in this presentation, on Dancitron and antihistamines used for nausea. And the nausea can be so severe that that pregnant women have to take these medications just to keep themselves hydrated and out of the hospital. But that can lead to, the side effects of constipation. Or women that are pregnant are prone to iron deficiency and are asked to not only take a prenatal with iron, but oral iron supplementation, which can be very constipating. Then there's the gestational diabetes and thyroid disorders that can contribute. The reduction in exercise and oral intake due to nausea, vomiting. We're also learning more about the maternal gut microbiome and those changes secondary to hormones, the adjustments in diet, clearly changes in sleep, as well as weight. So, there are many reasons why, pregnant women are suffering, and, they already have a complicated 9 months and postpartum that, finding ways to really manage this and be counseled on is really important. There are safe medications that women can take while pregnant. And it can be anxiety provoking because we know that there are many medications that should be avoided. And a lot of women, when they're constipated, probably don't know what to turn to. And here on this slide represents what is available over the counter. Fiber is a good place to start. There's fiber supplements that are soluble versus insoluble. Soluble is really what I would recommend as a starting place, one being psyllium. It's a robust, water-soluble, viscous fiber that holds on to a lot of water, bulks up the stool, keeps it nice and soft for evacuation. There are other agents over the counter, such as wheat dextrin, to consider, and these are considered overall safe in pregnancy, and women could take them daily to help prevent and treat constipation. Stool softeners, docusate, again, considered generally safe for very mild constipation. It may not be effective enough for moderate to severe constipation. Osmotic laxatives, the ones you may know of are polyethylene glycol or milk of magnesia. These are also considered to be safe, potentially needing to be utilized daily, or as Diana said, maybe for a certain amount of time and then can kind of wean off. But they work gently to draw more water into the colon. You know, polyethylene glycol is typically started at 1 capful, 17 grams daily, and mixed with about a cup of water, and can be slow and works over a few days to build up, and then can be taken on a consistent basis, similar to milk of magnesia. The stimulant laxatives, I would say, are not really to be utilized daily, but more as needed, and at the appropriate dose of for bisacodyl, 5 to 10 milligrams, 1 to 2 tablets. We know that there's unlikely to be having any systemic toxicity to use, especially for more moderate constipation. The same goes for senna. Lubricants, castor oil, mineral oil, saline agents, these are not recommended, you know, and I think this is the hard part. Women are given so many recommendations from family members, old wives' tales, friends, but we would encourage patients, pregnant women, to avoid the lubricants with management of constipation. I do want to highlight, and there are the over-the-counters, but there's the lifestyle modifications as well, right? You know, and for not only in pregnancy, but for anyone with constipation, you know, pregnancy safe exercise, obviously staying hydrated, being judicious with medications. If the constipation's so severe, you know, IV iron instead of the oral iron. Small frequent meals, making sure they're getting a lot of 25 to 30 grams of fiber through soluble and non-soluble, and as well as really sleep, which can be challenging to get as well. We're going to reflect again. Take this moment to maybe think of a patient you've seen, a friend, yourself, who's suffered from constipation during pregnancy, and you know, potentially what were the triggers and what seemed to work for that patient. You know, when I think of a common case of a pregnant woman, it's a woman, you know, who's gotten through their first trimester. They're zonked, they're exhausted, they haven't been able to eat well, they're not sleeping well, their progesterone hormones are just increasing, and they're nauseous, reaching for that ondansetron, trying to be on top of their prenatal, and then suffering from constipation, you know, transitioning into that second trimester. And this is where I really see a lot of women coming into GI, also struggling with hemorrhoids, rectal bleeding, which obviously you never want to take lightly. This is the common patient that I would be seeing here in my gastroenterology clinic. And again, focusing on those lifestyle recommendations, but you know, acutely addressing their constipation, maybe with the senna or bisacodyl, and you know, maybe, and then transitioning over to something like polyethylene glycol for maintenance, weaning down if no longer needed, maybe in the earlier parts of the third trimester that may need to be restarted, getting closer to delivery.
I'll just add real fast. I see it because I do a lot of actually pre-gestational and gestational diabetes management. So I'm seeing them for insulin adjustments, but it's common a woman will be started on iron, maybe her hemoglobin and hematocrit are low, and then that iron is triggering that constipation. So similar to you, starting off with a lifestyle, especially because of the diabetes, we don't want to have tons of like fruit and maybe not too many carbohydrates, but definitely non-starchy vegetables, great source of fiber and everything. And then transitioning to over-the-counter agents as needed.
I'm going to just make one other quick point too. I don't see as many pregnant patients as I used to in family medicine, but I used to screen for a fair amount of hypothyroidism that way, especially mid pregnancy as well. So thank you for mentioning that. Well, thank you both, Amy and Diana. This was really informative. I hope our audience found it equally as informative as we did. We thank you for participating in this activity. And please remember to scan the QR code to complete the evaluation and the CME post-test to earn your CME credit. Thank you very much.
Thanks, everyone.
Thank you.